fancy meeting all of you here. So tonight, I have some interesting things. I hope they're interesting to me. I hope they're interesting to you. I'm going to talk about some complex cases that I saw in the last week, and hopefully that will kind of spur some discussion. If not, I will make up some shit that will hopefully spur some discussion. But just to give you an idea, a lot of times, I hate to be like, a lot of times I see people writing things, doing webinars, giving lectures, and that noise is just Monkey trying to dig a hole in the floor to make himself comfortable. I see a lot of people giving talks, giving lectures, writing blogs, this, that, the other thing. And when I read them or when I see the talk, a thought goes through my head that this person doesn't actually see patients and that this person actually hasn't seen a lot of patients. And there's kind of like this common knowledge and this common information that people share when they are, teaching about certain subjects. And there are things that we tell you that it seems like they may be black and white. If this, then that. If A, then B, B, then C. And in real life and in complex, cases, which is primarily how I spend my day. Beth, can we just get a mute on? Somebody is unmuted. And if you could just figure out who they are and shoot them out of the sky. It very rarely does a patient come to you with a straight down the line A, B, C, D, E. And so I wanted to go through a few of my cases from the last week. Don't worry, it's not going to be boring medical details per se, but just so you get an idea of like who I see, what my thought process is when I see them, because it often will help you with your thought process as how do you get the most out of your care, and how do you think of things that are not run of the mill, and how do you help your doctors think of things that are not run of the mill, and how do you find doctors that can think of things that are not run of the mill? Because in today's fast-paced medical world, things happen. You get your 10 minutes of fame with your doctor, and if you can't spit everything out in those 10 minutes, and the doctor doesn't, it's very, very hard, especially when you have a difficult case with multiple medical conditions. And especially during COVID, there's often such a lack of continuum of care because there's so much time in between the time that we see our medical professionals. So it's like by the time you get back to see them again, it's like you may not have the same problem, or you may have that problem plus 5 other problems. I want to thank our sponsors tonight, Care Inc., who is my favorite oxygen company for a number of reasons. It has nothing to do with any type of financial support or anything like that. I think their machines are great. I think their machines do what they say they're going to do. I think there's truth in their advertising and truth in their selling. And I think they're really nice people. So thank you very much to Care Inc. And I want to also say, this is not a lecture. So this is something where, you can feel free to share. You can feel free to ask questions. This is open time. I'm happy to answer questions. None of this is scripted. And I don't think you'll throw me off. If you do, it might be entertaining for you. And then just the other thing I want to say is that the Pulmonary Wellness Foundation is a small foundation that is basically run by a handful of dedicated professionals. And when I say a handful, I mean like half a hand of people who show up every day, don't get paid, volunteer their time, services, et cetera, et cetera. And, contrary to some of the other foundations, not to say anything negative about them, but we're not a giant corporation, okay? And our CEO doesn't make $500,000 a year. So if you would like to support us and you do appreciate the work that we do ask you to go on our website, pulmonarywellness.org, and support the foundation with a weekly, monthly, annual gift, one-time gift. But this is how we continue to provide services to you. And then the last thing I'm going to say is that you may see some subtitles, and you may find that very helpful, or you might find them annoying as hell. If you find them annoying as hell, then you can turn them off by going down to the bottom of your screen where it says live transcript, and it can say show subtitle. And if you don't want it to say that, you could say hide subtitle. And I'm going to go one at a time through my cases from one day last week, and then I'll open it up to questions. So I'm going to start with the first one. And the first patient that I saw last week was a 68-year-old female. The majority of patients that come to me at the Pulmonary Wellness and Rehabilitation Complex, the single factor that unites them all is almost all of them are short of breath. But I'll just read to you. So essentially, 68-year-old female, chief complaint, severe shortness of breath, decreased muscle strength, and markedly decreased activity tolerance. And just so you know, like, chief complaint is an actual thing. Like, that's a part of your medical chart. And as it sounds, that's supposed to be the most significant part of your care. So why did you show up today? I have a cough. I'm short of breath. I'm having chest pain. My knees hurt when I do this. But as you know, life isn't existent in a linear fashion, and it's not always existed in a nice, neat box tied with a bow. Often patients come with multiple chief complaints, and sometimes the things that people say first aren't even their most significant complaint, but you've been waiting for 2 months to see the doctor, and then you get there, and before you know it, you forgot what you wanted to say, and you wind up telling them something that you weren't even planning to tell them. So, you know, again, that's just a plug for organizing yourself before you go to the doctor. According to the patient, she was hospitalized in 8 days in April after passing out and going to the emergency room. She states that her breathing difficulty began several years PTA, which means prior to admission, which means ago, and has become progressively worse over time. Now listen to this. Her medical history is significant for asthma, pulmonary hypertension, congestive heart failure, arrhythmia, and permanent pacemaker. At this time, the patient states that her breathing difficulty has become progressively worse over time, and that her lifestyle has been significantly impaired by severe shortness of breath, decreased muscle strength, and markedly decreased activity tolerance. So asthma, pulmonary hypertension, congestive heart failure. And when somebody has heart failure, we wonder, why do they have heart failure? And so we have a pulmonary issue. We have multiple cardiovascular issues. And, you know, when I go through a patient's case, I go system by system by system. But the first thing that I do, and it doesn't matter what kind of patient it is, because when a patient comes in, I approach almost all patients in the same way, with the exception of COVID patients. And the COVID patients I treat a little bit differently, but my evaluation process is mostly the same. And the first and foremost order of business is to look for potential life threats, okay? And what I mean by that is, as it sounds, I want to make sure that when I put somebody up on a treadmill, I'm not going to find out the hard way that they have something dangerous going on with them. By the time a patient gets to rehab, they should really be, you know, medically stable, which medically stable is, you know, sometimes an oxymoron, right? Because a lot of things get missed. And one of the challenges of dealing with patients with complex medical conditions or multiple medical conditions is that very often when you are diagnosed with a chronic illness, everything that happens to you is attributed to that chronic illness. And particularly when you have heart disease and or respiratory disease and or gastrointestinal problems and or musculoskeletal problems. This can be a huge challenge to the healthcare professional, because a lot of the things that cause heart disease are also risk factors for respiratory disease. A lot of the symptoms of heart disease and cardiovascular disease are also symptoms of respiratory disease and or gastrointestinal disorders. And so it's often very difficult, especially in an extremely limited amount of time, to dissect every single system one by one and ask the questions that you need to ask to make sure that you're considering all of the possibilities. I like all of you. I trust all of you about as far as I can throw each of you. Okay. And why do I say that? Depending upon the patient, some patients will come in with a 2-page typewritten day-by-day assessment of their last 50 years, starting on the day they were born and going up to their 72nd birthday, which was last week, and everything that they've ever had done, including removing the Band-Aid from their knee when they were 7, is included on that list. Other patients come in, they have nothing, okay? But what I do when I see a patient, and I typically will set aside an hour and a half for my initial consultation, because that's about the amount of time it takes for me to make sure that I can at least cover the tip of the iceberg. Okay. It doesn't mean that in an hour and a half, I'm going to learn each and everything about you, but it tells me that I know I can get through every system. I know I can ask the important questions to not eliminate life threats, but at least determine if I think we have some life threats, and to set us on the course to, a physical exam and some physiologic testing with you, and setting you on a rehab course that hopefully is going to be safe and effective for you. It's also going to hopefully elicit something that might be dangerous for you. So we'll take it from there. When it comes to, again, people with multiple medical conditions, a lot of times everything that you have is attributed to that. So just a show of hands, how many people here in a typical week, so in a typical 7-day period, experience shortness of breath? Okay, hands down. In a typical week, how many people don't experience shortness of breath? All right, so everybody here experiences shortness of breath at one time or other, including myself. I live in Murray Hill, which, if you know New York City and Murray Hill, it's a big hill, okay? How many people here at one time or another in the course of a week experience increased pressure in their chest? Okay. How many people raise their hands for both of those? Raise your hands again. Okay, so quite a few people here experience shortness of breath and or pressure in their chest. So my question to you would be, how do we know if it's chest pain coming from your heart? How do we know if it's increased pressure coming from your heart? How do we know if it's shortness of breath coming from your lungs? How do we know if it's shortness? How do we know if it's increased pressure coming from your lungs? Or how do we know how many people here, show of hands, experience shortness of breath and or chest pressure and or bloating? Okay, see, not everybody wants to raise their hand to bloating, right? Because that one could be embarrassing. Be like, yes, I have bloating, I must admit. But the thing about it is, if you think about it from here to here, right? We have our cardiovascular system, we have our respiratory system, and we have our GI system. And my point in talking about this is that a lot of the symptoms of the cardiovascular system can be confused with respiratory and can be confused with GI. And again, if you are somebody who's been seeing your doctor for 20 years for COPD, well, maybe they don't think about heart disease, or maybe they don't think about reflux, or maybe they think of reflux, but it's really heart disease or respiratory disease. And so what's really important is that we elicit the correct information and we eliminate information that could be false. One of my areas of interest is exercise testing and exercise prescription. And when it comes to cardiopulmonary patients, particularly respiratory patients, it's often very difficult to get a good exercise test that is really going to be representative of the patient. And when you think about it, let's say you have had COPD for 20 years. You come in, you say, doctor, I'm short of breath. And the doctor says, well, that's your COPD, or that's your asthma. And you come in and you say, I have increased pressure in my chest. You say, well, you know what? That can also be COPD. Right? And that can also be asthma. And you can say, well, you know what? After I have a big meal, I get even more short of breath. I don't understand this. I walked to the restaurant and I was fine and had dinner. And then when I came home, I had to take a taxi 3 blocks in order to get home. I couldn't breathe anymore. Right? And all these things are connected. It's like we had a patient that came in one time and he said, it hurts when I press over my heart. And he also said that it hurts when he presses over his right lung. And he also said it hurts when he presses over his left lung. And just to make sure that he wasn't having a neurologic problem, I asked him to press over here and see if it hurt. And he said, yeah, that hurts also. And this guy had a broken finger. But if I didn't do some, some testing, some really complex testing, we never would have found that out. And we could have made the mistake of assuming it was his heart or his lungs or his GI system. But my point in telling you that part of it is that if you're having a problem and you're having chest pain and you go to the emergency room and everything in your heart checks out and it turns out that, hey, it was just gas, or it turns out it was that bean burrito that you had for lunch, as I like to say, well, then that's just a kind of funny story, or it's an inconvenience that you took a ride to the emergency room, but you got information that actually says you're okay. But for those of you that don't know, one of the #1 symptoms of having a heart attack or having a cardiac problem is denial. Okay. And so if you assume, hey, it was probably that beef burrito or bean burrito that I had today at lunch, and it turns out to be your heart, well, then we have a situation there. And so part of what I try to do in teaching both patients and clinicians is, yes, from Steve Covey's 7 Habits of Highly Effective People, keep the main thing, which is make sure that we always look for the most significant problem, meaning the one that's giving you the most difficulty and also the one that's going to be the most dangerous, but don't jump to the assumption that that's it. So wheezing is often, you go to the doctor, say, I've been wheezing. So you know what, you must have asthma. Or you go to your doctor and you say, my knees hurt when I walk up steps, and say, well, you must have, osteoarthritis. Or you say, oh, I have, itching when I do this. And the thing is that sometimes it is exactly what you think it is, but sometimes it's not. And doctors don't usually send me patients when everything is going according to how it's supposed to go. They usually send me patients when things aren't going well, or when, they've tried a lot of different things and they basically are out of ideas. And so, when I talk about risk stratification, or when I talk about keeping the main thing, there are 3 things that I worry about more than anything else, because don't get scared at what I'm about to say, but these are the things that could potentially kill your patient quickly, okay? And the things that I worry about most are, #1, not in any order, coronary insufficiency, okay? Heart failure and arrhythmia. Now, if you don't know this, okay, we think of ourselves as having one heart, right? Show of hands, how many people think we have one heart? All right. Show of hands, how many people think the heart is a pump? All right. Show of hands, how many people think we have more than one heart? Helen, you think we have more than one heart? Helen, how many do you think we have?
We have one in the bowels too.
We have a heart in the bowels. This I did not know, but I'm scared to do this on live air. So I think we better talk about this offline, and then at another point in time we might be able to discover. You know what? I'm going to tell you a funny thing right now, Beth. You're going to like this, because you asked me the other day if these words just pop into my head, right? But there's a kind of there. If you're afraid of cursing or inappropriate humor, just hold your ears for 45 seconds. But I was going to say we can talk next week about the ass heart, okay? But it reminded me of the ass hat that Beth loves to use. And then in other countries, they call it the arse. So it's like the arse hat or the ass heart. And you can see why a lot of people think I'm an ass. But anyway, moving forward. But the idea is that the heart is actually made up of 2 pumps, okay? The heart is, and I think of it more so as a right heart and a left heart, right? Because the right heart and the left heart do 2 very different things. It's not like the heart is this central organ that pumps in this even way. The left heart is I almost said the left heart is the right side of the heart. The left heart is the high pressure side of the heart, right? And does anybody know why the left heart is the high pressure side of the heart and why the left heart is the big side of the heart? Adele, do you want to tell us?
Yes, because the left ventricle pumps the blood out to the body, not the right side just pumps to the lungs.
Bingo. Don't go anywhere because I may need you for some other stuff. So the left side of the heart pumps to every area of the body. It's got to go far, right? It's got to go up to our brain. It's got to go up to our fingertips. It's got to go down to the tips of our toes, right? So it's got to be strong. The right side of the heart pumps, you said just to the lungs, okay? As a lung aficionado, I'm going to try not to take offense to the fact that you said just the lungs because they happen to be my favorite organ, okay? But the thing is that they only have to go a few inches, right? And so that's why the right side of the heart is smaller. It's less pressure, okay? Because it only has to go a short way. And these two things have caveats to them. And those caveats are if everything goes right, okay? Meaning that if everything is working properly, then the right side of the heart is going to be low pressure. And if everything is going properly, then the left side of the heart is going to pump everywhere in the body. But there are things that can go wrong. And, you know, people talk about the idea that the ankle bone is connected, you know, that the foot bone's connected to the shin bone or the knee bone's connected to the hip bone. Well, there's a similar, I don't think anyone's made it a song yet, but there's a similar type of relationship, you know, in the cardiopulmonary system. And what I mean by that is there's often a starting point, right? So, you know, your feet hurt because you stand on your feet all day. And so you wind up turning your ankle this way, and that requires your knee to go that way and the hip to go the other way. And everything's got, you know, an impact. Everything has some kind of, you know, what's the word I'm looking for? Some kind of result as a result of the initial impact. So let me just give you an example. And let me make it easy by showing you a picture of the heart. Let's take a look at, I'll share my screen with you for a moment. Okay, so if you look over here, this right here is the right ventricle, okay? And this is just kidding. That's just a that's like a Valentine heart. I'll use a real heart. So here we go. So here's the heart, and the way that we're looking at the heart right now is we're looking at the person head on, and it's as if their chest has been cut right down the middle, and this has been peeled away. And this is our left ventricle. This is our left atrium. So we have the two top chambers of the heart, and these mirror each other. But again, this is the high pressure side of the heart, low pressure side of the heart. The left atrium, let me just clue you in on a little bit of anatomy. Blood flows from the left atrium into the left ventricle through this valve right here called the mitral valve, okay? From the left ventricle, the blood goes through the aortic valve to the aorta, which is the largest artery in the body. And from there, it goes to the rest of the body. The right atrium delivers blood. Well, blood flows from the right atrium through the tricuspid valve into the right ventricle. And from the right ventricle, it flows through the pulmonic valve to the pulmonary artery. And just a fun fact, the pulmonary artery is the only artery system in the body that carries deoxygenated blood. All the other arteries carry oxygenated blood because they're coming from the lungs, and the pulmonary veins are the only venous system in the body that carries oxygenated blood because they've just come from the lungs, and they're now going back to the left side of the heart where things are going to go to the rest of the body. So now let's talk about this for a second, okay? Let's say hypertension, right? A lot of us talk about the idea of hypertension or blood pressure. And some people don't recognize the importance of high blood pressure, or they think it's something that they can't really feel. And so it's hard to be aware of your blood pressure. And so sometimes it's easy to kind of overlook the significance. But just as one example, if you have chronic high blood pressure, what winds up happening is the left ventricle has to work even harder to overcome the pressure of the peripheral arteries. And as a result, the left ventricle can increase in size, okay? Like any other muscle, if the left ventricle has to work against an increased resistance, it will get thicker, it will get wider, it will have what's called LVH or left ventricular hypertrophy, and it will require more oxygen. The other thing that can happen is that if this is my left ventricle here, and I turn it up like this, on top of it is my mitral valve and my mitral ring or my mitral annulus, okay? And as this ventricle hypertrophies or gets bigger, it can stretch the mitral annulus, and as a result, the mitral valve doesn't close properly anymore. And as a result, when the left ventricle contracts and blood is supposed to be flowing forward, it winds up flowing backwards also into the left atrium, and that's what's called mitral valve regurgitation, okay? Now, if that continues, okay, remember that blood is coming from here into the left atrium from the lungs themselves, but if things start to back up, okay, from the left ventricle, through the mitral valve, through the left atrium, back into the lungs, that's the very definition of heart failure, left-sided heart failure, okay? So the things that I worry about most are heart failure, arrhythmia, and coronary insufficiency. And when we talk about those different things, in addition to not just being one heart, in addition to it being, in addition to it being two pumps, it also has three separate systems. And the separate systems related to the heart are the electrical system, the mechanical system, and the vascular system, okay? And so when I talk about coronary insufficiency, I'm talking about the vascular system. And what I'm talking about is the coronary arteries, the arteries that deliver blood and therefore deliver oxygen to the heart muscle itself. And if that's not doing its job, you wind up with what's called coronary ischemia or coronary insufficiency, and that's what causes angina or angina, okay? That's the vascular system of the heart. Then we have the electrical system of the heart, and the electrical system of the heart has to do with your cardiac rhythm, okay? That's where you hear words like normal sinus rhythm, atrial fibrillation, PACs or premature atrial contractions, PVCs. And, sometimes I think patients hear these words or see these things in their charts, and it kind of sounds like a cardiac soup, right? And it's like you don't recognize that there's actually lines down these things, and it's an extremely organized system. And then the final area of the heart is the mechanics of the heart, okay? And the mechanics have to do with the pumping power of each chamber of the heart, and it also has to do with the valves itself, okay? Now, here's the important thing, and then I'm gonna stop and take a break for questions and or comments, okay? But the thing is that this is really like a triangle. And if one of these says electrical and one of these sides says mechanical and one of these sides says vascular, or in other words, if one of them said heart failure and the other one said, coronary insufficiency and the other one said arrhythmia, any one of them can negatively impact the other one. So in other words, if you have an arrhythmia, that can affect your ability to deliver blood and oxygen to the heart. If you have an arrhythmia, it can also affect the mechanics of the heart. If you have a problem with the mechanics of the heart and you can't pump blood to the various areas of the heart, that can affect the electrical rhythm of the heart, and it can also affect the delivery of oxygen to the heart itself. And if you have a problem delivering oxygen to the heart itself, that can also affect the mechanics, and that can also affect the vascular as well. And that can also affect the cardiac rhythm. So if I go back quickly for a moment to my patient that I was talking about before, essentially when we talk about, when we talk about somebody who comes in who has asthma, okay, and who has pulmonary hypertension, okay, and who has heart failure, then we're talking about people who wind up being able to have an impact in multiple different areas, right? Because asthma affects the airways, right? Asthma affects the airways, and that can also affect how your body uses oxygen, because how your body uses oxygen is based on three main things. How good are your lungs at moving air in and out? How good is your heart at pumping blood? And we've already talked about the three things that have that. And then how good are your muscles at using oxygen? And all these things are connected. And that's why it's so important that when you go to a doctor, they don't just make a quick knee-jerk reaction and say, it's that bean burrito you had at lunch today. We have to trace every system. We have to look and ask all the questions and make sure that there's not something we miss. And we have to make sure that there's not something that's pointing us to a more dangerous situation and not just something that's symptomatic. Okay. I love surprises, just not in my professional life. Okay. So I don't want to find out by accident that my patient has heart disease. And a lot of times we find out not by accident that our patients have heart disease, because think about this, the stress test. How many people here have had a stress test on a treadmill before? Raise your hand. Okay. How many people have felt like they've failed the stress test? There's no such thing, but I have people come in and say, I say, why are you here? And they say, because I failed the stress test, right? The stress test that is used for diagnostics in terms of heart disease is a very poor stress test for people who have other medical conditions and particularly respiratory disease. And the reason for that is because it starts off very fast. The majority of stress tests start off at 1.7 miles per hour with a 10% incline, okay? Which if you have emphysema or chronic bronchitis or asthma or something like that, or you haven't, been on a treadmill in 10 years or so, that seems like the snail is walking and a turtle speeds by him and he goes, whoa, that guy was fast. And the thing about it is that very often the tests are not stopped for a hemodynamic or a cardiovascular reason. The tests are stopped because you're either short of breath or because your legs are too tired, right? And so if you only do 2.5 minutes on the test, and I'm using 2.5 minutes as an arbitrary number, but the test was stopped because you were short of breath and or your legs were tired, we've learned nothing about your heart, right? So I had a patient last week who was in this boat, similar situation. We couldn't tell, again, is it heart? Is it lungs? Is it something else? And they wanted to do a treadmill test with this patient. And I would say insisted, but I would say more so begged for them to do a pharmacologic test, where a pharmacologic test is where you're given medication that simulates exercise. And it doesn't matter if you can walk hard or fast or high, but we get the information. And another thing that we see very often is that a patient has no idea that they have heart disease, right? They know they're short of breath. They know they have lung disease. They know they have difficulty walking up a hill or up the stairs, but no one's ever given them a thorough heart exam. And then they do rehab. And now that they're getting into better shape, guess what? Now they're starting to get chest pain. And they're not getting chest pain because they do rehab. In other words, the rehab is not giving them the chest pain, but before their shortness of breath, and you can also substitute hip pain, back pain, leg pain, knee pain, anything else like that, didn't allow them to ever get up to a level of exertion that was able to elicit their cardiac problem. So it's like a good news, bad news situation. The good news is, hey, you're doing much better. The bad news is, hey, we found out you also have heart disease, but that's also really the good news, because I'd much rather you have a problem in my office. And I'm not looking for anyone to have a problem, but I'd rather you have a problem in my office where at least I can help you, as opposed to the old Lord and Taylor. Number one, because it's closed down, and so you shouldn't be in there anyway. But number two, you need to find these things out. And a lot of times people think that it's only their lungs, and then they wind up getting a stent, or they wind up treating their blood pressure, or they wind up treating their coronary insufficiency. And guess what? Life gets a lot better. Okay. But it requires having a medical team that is interested in really finding out everything about you and doing it in an orderly way. I say all the time, I have two, the truth of the matter is that 99% of what I know about patients, I learned from patients, but I always say, 99%, 95% of what I know about medicine, I learned from watching House MD. And if you watch House MD, I'm telling you, it's really the utmost in differential diagnosis. And not a lot of doctors do differential diagnoses these days. Unfortunately, what happens is there's this knee jerk, you have wheezing, you have asthma, not let's go through every possible thing that it can be and then rule out all the things it's not to come to our solution. Questions, comments? I will, if you want to ask a question or comment, please raise your hand. I will unmute you, or I will call on you and then go to the next person. you know, just please, if you could raise your hand with the reactions button. If you go to the reactions button at the bottom, you'll see something that says raise hand, and you'll notice that I got moved to the front. Okay, so you can not only see yourself move up in the world, you could see where you are on the line. You can know how much time you have left till it's your question. I'll also tell you who's on deck. So let me put my hand down. All right, Sylvia Dimon. How do you say your last name? So Dimontini. Dimontini. And then Johanna, you're on deck. Sylvia, go first. You can unmute yourself. Johanna, unmute yourself because you're on deck.
Hi, Sylvia Demonsny. I had a myocardial perfusion scan
Yep.
a couple months ago, and what would that be measuring as opposed to your standard treadmill stress test, which I had last year, and then I had a stent.
So that's a great question. So, you know, when you talk about diagnosing heart disease, right, or most things in life, but particularly heart disease, okay, there's a great kind of continuum in terms of, you know, so not everybody who has a chest pain or something like that is going to go through the whole testing procedure, right? You start with the least invasive tests that are going to give you the most bang for your buck, and then you work up. You know, if things still aren't found, you work up to more invasive tests that come with greater risk. But just as an example, what do you learn from each test? Okay. And I'll put this in the context of the 3 systems that I talked about before. So if you recall the systems, okay, we'll do it like this. One of these things is not like the other. So we have the root system, right? We have the vascular system. We have the mechanical system, and we have the electrical system. So one of those is not related to the heart. How many people say vascular system? Raise your hand. How many people say electrical? How many people say mechanical? How many people say root system? All right, the root system people are correct. If we were talking about trees, the root system would be very, very important. That's the vascular system of the tree. But here we go. How many people have had an EKG? Pros and cons. Pros, simple test to do, completely non-invasive, right? And what do you learn from it? Okay, you learn about the electrical system of your heart. Okay, you can see usually 12 different views of the heart, and those 12 different views of the heart are telling you about the electrical system of the heart directly, but we can get an indirect measure of the mechanics and the vascular system from that. So in other words, you're looking at the electrical rhythm of the heart on the EKG paper, okay? But there are certain things on that EKG paper that can point to a coronary insufficiency issue and can also point to a mechanical issue. As just one example, left ventricular hypertrophy, okay? So the good side is easy test to do, okay? Non-invasive, it's fast, it takes 1 second, and you get a fairly good amount of information. That's the pluses. Here's the minuses, okay? It's like a snapshot in time. So what that means is click, we're getting a 6-second view of what your heart is doing right this moment. You've all heard the stories about somebody who you say, you know what? I don't understand this. The guy went to the cardiologist, okay? Cardiologist said everything is great. They walked out the door and dropped dead in the street, right? And the thing is, sometimes when people say, oh, my heart is okay, and all they've done is an EKG, okay, I want more information, okay? Because the EKG, again, is going to give you a direct look at the electrical system of the heart. It's going to give you indirect information about mechanics and vascular, okay? But it's only at that 6-second moment in time. And it's like taking a photograph. It's like you have your kids and they're smiling nicely for the photograph, right? And then the photographer puts the camera down, or you turn your head for a second, and one of them punches the other one, right? That could happen in your EKG too. So your EKG could be normal. They take the strips off, then you come out, you get a punch in the heart from your heart, right? So that's the easiest test though. So in other words, if you walk in, you're like, oh my God, I'm having chest pain. Do an EKG, can see if there's coronary ischemia there, can see if there's an arrhythmia there. Can't tell too much about the mechanics, but you can tell if somebody's having a heart attack, okay? Next order of business, echocardiogram. Echocardiogram, how many people have had an echo? Ultrasound of the heart, right? So usually you get an echo like this, it's a transthoracic echo, which means it's going across your thorax. It's an ultrasound that's looking at the structures and function of your heart. So it's giving you a direct look at the mechanics. And remember that triangle that I told you about before. So the mechanics can give you an indirect look at the electric and the vascular, okay? So you get a lot of information from that. You get a look at the ventricle, the atria, you get all the chambers, right? You can get an ejection fraction from that, okay? You can look at the valves to see if the valves are functioning properly. And there's basically two types of problems that can occur with the valves. They can be, and I always say it like this. There's three things you could have with the heart, and we could do it Goldilocks style. So you could say, this valve is too tight, this valve is too loose, this valve is just right, okay? And if the valve is too tight, that's called stenosis. And if the valve is not tight enough, that's called insufficiency. And insufficiency can lead to regurgitation, which means blood is flowing in the opposite direction that it's supposed to flow. So there's that. That's an echocardiogram. Pluses, you get a lot of information from it. You get direct mechanical, indirect coronary insufficiency, and electrical. Non-invasive, you can, unless you get a TEE, transesophageal echocardiogram, which is where they go in through your esophagus and the camera is dropped behind your heart, where you get a better view of some things that you can't see on a regular echocardiogram. The good news about an echo, it's not just a moment in time. It's pretty good, it's a pretty good judge of kind of where your heart is over time, right? And you can compare an echo 1 year to an echo another year, okay? Then we talk about some other studies where we're talking about the coronary, the coronary blood flow. And Sylvia, you said the myocardial perfusion study. And what we're talking about now is two things, okay? So you can have an angiogram, and you can have, there are a number of different tests. There are nuclear tests, right? And what happens during these tests is when you have an angiogram, a catheter is inserted either in the groin or the arms, and it's brought into the heart, and a dye is injected so that you can see the coronary arteries. And when you look at the coronary arteries, what you can see is you can actually see the diameter of the coronary arteries. You can see blood flow through them, and you can see any type of plaque, atherosclerosis, et cetera, et cetera, et cetera, et cetera. There are other tests in which you'll be given an isotope, okay? And this can also happen where you are given a medication, like I said before, that will simulate exercise, right? And the reason why it's important to see the heart under stressful conditions is because very often, and this goes for the lungs too, but people are perfectly fine when they're sitting and doing nothing. All systems are go, okay? But when they get up and move around, that's when either their shortness of breath or their chest pain or their coronary insufficiency or their heart failure will kick in, because it's based on supply and demand. And the demand for myocardial oxygen supply is low when you're sitting and doing nothing. And then the more activity you do and the more vigorous the activity, the greater the demand. And that's where your deficit will show up. But Sylvia, what happens is, as opposed to looking at the coronary arteries themselves, you're given a medication that is supposed to be uptaken by the heart. And then instead of seeing the actual vessels, what you're seeing is a picture of the heart, and you will see areas. Usually what they'll do is they'll give you an injection, then they'll put you in a tube and they'll take a picture, okay? And then you sit for a while. And can you hold on for just 1 second? I hear that a dog might be misbehaving in the other room. Give me one moment. The dogs were all behaving. Okay, so the difference between one is where in one of them, you're actually looking at the vessels themselves, but in the other one, what you're seeing is, can the heart muscle actually take up the isotope that mimics blood flow? And so the reason why you take a photo, let's say for argument's sake, you take a photo and you can see an area of the heart where it looks like, okay, there's no blood flow going here. Right? So you see, let's say a dot, and this dot, or you see a spot, let's say, because a dot sounds too small, where there's no blood flow to this area. Now, that could say to you, okay, no blood is going to that area of the heart. and that could be indicative of a blockage, right? And the reason why they do this test a few hours later is because one of two things can happen. That area where there was a spot where you weren't getting coronary blood flow can either fill in, right? Or it can remain. And if it remains, what that means is that you have an area of necrotic tissue or an area of scar tissue, meaning you've had a myocardial infarction or a heart attack at some point in time, okay? If it fills in, what that means is that the tissue is alive, the tissue is viable, but you have a blockage to the blood flow there. But what you also have is something called collateral circulation. And what that means is that when you have an ischemic area, there are some people, okay, who when one artery is blocked, they have the ability to have this function called angiogenesis, which means to create new blood vessels, and they can actually get blood delivered from other vessels, and it sort of comes around the back. And there's a similar phenomenon in the lungs called collateral ventilation, and this has a lot to do with secretion clearance, and a lot of people may hear that term if you're going to be evaluated for the valves, the endobronchial valves, because that also is a determinant in how it's done. But essentially, Sylvia, you're looking at the myocardial uptake and the actual uptake of the muscle tissue itself, of blood, of oxygen, of the isotope to determine, is blood flow going there? And if blood flow is not going there, is it slow to flow, or is there actually a heart injury? Johanna Majorano, Brian Patterson is on deck, but as you can tell by my very short answers, you might not have to unmute yet, Brian. But Johanna, go right ahead. You're muted. Yep,
Yes,
unmuted.
here I am.
Hi.
Oh, wow. Um, all of your examples are situations, it seems to me, that, you know, none of us can be asking to have particular tests. Something generally has to have happened before we're sent for a test. Like echocardiograms. I mean, if I go and ask my doctor to send me for an echocardiogram, I don't know that she would agree to it, or, you know, in terms, unless there's something that I'm aware of, there would be the question, why am I doing this? Is this something, I know, you know, when I first came to the Pulmonary Wellness Center, I thought you did a very thorough intake. And I know that the doctor, I don't know if the doctor sent you a report or vice versa, but is it something that during the process of working with your team, that things get identified that are then, we're then advised to have a particular test done, or?
Yeah, absolutely. So in other words, like I am not a passive participant, okay? Like I'll give you an example of something that happened last week. Was we had a patient who came in, and during the exercise session, he developed chest pain, substernal chest pain with radiation down his left arm. Classic, okay, classic coronary pain. I wanted the patient to go to the ER. Patient wouldn't go to the ER. But in a situation like that, I'm going to get on the phone with their doctor. I mean, and I handle things in real time. So, you know, if I think something's dangerous, I'm going to send you to the ER. Now, you don't have to go to the ER. Okay. Right. I've had people try to escape the ER, and some people have escaped the ER. But if I think that, you know, if I think that you are having a potentially life-threatening situation and you don't allow me to do my job. And I had another situation where a patient was also came in very, very low blood pressure, having an arrhythmia as she walked in. Heart rate was in the 150s, blood pressure was about 80/50, very, very sweaty, in trouble, you know, in trouble because of the arrhythmia. And patient didn't want to get treatment, and you have the right to choose, unless you're my parents. Like last week, my parents called me about something. They didn't want to do anything, and I called the ambulance on them without them knowing. I had no choice. But I won't do that to you. But the thing is that if when you come to me, it's a trust between us, right? You trust me to take care of you, and I trust you to be honest with me
Right.
and help me take the best care of you. So if you're going to come to me with things that are, if you're going to come to me and in a situation where I think there's something that's potentially dangerous for you, and you're not willing to follow my recommendations, I mean, then we're not going to get along. I'm going to tell you, I'm not going to take you as a patient. I'm going to refer you to someone else,
Right.
or I'm not going to see you anymore. Because bottom line, there's a reason why we have a perfect safety record. And, don't get me wrong, I'm not so arrogant as to think it's because of us, nothing has gone wrong. I mean, I know for sure, you could do everything 100% right. If you get the wrong person on the wrong day, something could go wrong. But my team trains every day to make sure that if we do have an emergency, it's well handled. But the thing is, I'm like, at this patient who had the chest discomfort, he is planning a move soon, okay, and also planning to have cataracts done. And I was like, you're not having these things done until you get this thing done. Now, he didn't want to go to the emergency room. Okay. My next offer is, well, let me call paramedics here and let's get an EKG. Let's get a 12 lead EKG. When we exercise patients, everyone's wearing an EKG, but it's only a single lead telemetry. Okay. So from single lead telemetry, what I could determine is I can determine your heart rate and I can determine your basic rhythm, but I'm only looking at one view. It's not like a 12 lead EKG where I'm looking at 12 different views of the heart. And so there are things that can be missed on what we have that can be picked up on a 12 lead EKG. But essentially what I did was I sat down with the patient and I called their doctor and I put them on speakerphone. And that's the conversation that needs to be happening. And when I'm doing that, I'm not just teaching the patient how to interact with their doctor. I'm teaching my staff how to interact with the patient during an emergency and also how to interact with the patient's doctor. But also I'm holding everybody accountable, right? I'm saying, hey, guess what? Now it's out in the open. Okay, we have this documented call where we're all in agreement that the patient has a situation. Patient can choose to do something or not. Now, if you choose not to do something about it, and
Right.
something happens to you, I mean, I will do my darndest to convince you to do what I want. Not because I'm a control freak, okay? And I'm not saying I'm not a control freak. I'm just saying that's not why I do that particular thing. It's because I have a lot of experience. And it's because I have 30 years of cardiopulmonary rehab experience and 20 plus as an EMT in New York City. So, I know when something's going wrong and I
Right.
want you to be taken care of. And sometimes you're right, Johanna, you may go to your doctor and you may say, hey, can I get an echocardiogram? And your doctor may be like, why is this patient telling me what to do? They didn't go to medical, but once we kind of have that open conversation, everybody's in a position where they have to act, right? But I work with mostly good doctors, and the thing is that this patient was going to move recently, and the doctor said no, and he's having catheterization on Friday, right? Because when you have something, and let me just point another concept out to you, which is stable versus unstable, right? You can have a condition that's stable and chronic. You can have a chronic condition that's stable. COPD or respiratory disease is generally considered a condition that has exacerbation and remission, meaning there's times where you are feeling pretty good and you're well managed, then you can have an exacerbation or infection, and things get worse, and then you hope to restore stability again. Angina, okay, like chest pain, can be stable, meaning that it's predictable. It comes on, at the same level of exertion. So in other words, I walk up 2 flights of stairs, then I get a 3 out of 10 chest pain that lasts for 30 seconds, right? So I'm marking these things out for you. So I'm saying, after 4 blocks, I get a 7 out of 10 chest pain that I have to stop. And after 3 minutes, I can start walking again. Now, if all of a sudden, instead of 2 flights of stairs, it's coming on at 1 flight of stairs, or if all of a sudden, instead of, 3 blocks, it's coming on at 2 blocks, or it used to be level 3 out of 10, and now it's level 5 or 6 out of 10, or it's happening more frequently, or it's taking longer to resolve. Those are all indications that something has changed in your physiology, right? And that's where I would consider it unstable. And that's where I would consider it a potential emergency. And, in a situation like that, I think that at least an evaluation should be imminent, and a intervention may be forthcoming, right? Because guess what? If you have a problem on the third day and you would have waited till the fourth day, you might have been in trouble. So to me, when I see anything that indicates that a patient might be unstable or that they have a dangerous situation going on, I want to handle it immediately. And you're right, not all doctors are, but you see, you wouldn't go up to a doctor necessarily and say, hey, you know what, I'd like you to order an echocardiogram. That's a little bit arrogant. It's a little bit inappropriate, right? I mean, this is the age of what I call the expert patient or the patient expert, okay? If you're on Facebook, a lot of people consider that the equivalent of 4 years of medical school. If you have Facebook and Twitter, that's like your residency. If you have Facebook, Twitter, and Instagram, you're a fellow, okay? But the idea, and it's funny, one of the best memes of the year, when the Ukraine situation started, people said, and just like that, everybody went from being an infectious disease expert to a foreign relations expert. But the thing is, you're not going to go and tell your doctor what to do, but you're going to say, can I ask you a question? I'm 75 years old. I have this respiratory problem. I have some cardiac risk factors. Are there any tests I may need? You've done an EKG. Would it be worthwhile for me to have an echocardiogram? Do I need an angiogram? And nobody's going to send you for an angiogram right off the bat. Nobody wants to. It's invasive. It's potentially more risky, but an echo is an easy test to do. And it's going to give you kind of like, do we need to stop? Can we stop here? Or do we need to go further? And might we need an intervention in the future? But a lot of things are the way you say them, not what you're saying, but how you say them.
Right. Exactly.
So you're right. I think it's a challenge. And I think it's a challenge because, again, the medical system is stretched to the limits these days by, number one, volume. Number two, so many people have left the medical professions. Number three, what insurance companies allow or don't allow. And as a patient, you can't be expected to be an expert, okay? You're not expected to be an expert, okay? The doctors are supposed to be able to say, hey, you know what? You're 75 years old. You've had high blood pressure for a long time. You've had high cholesterol for a long time. You're overweight. You're sedentary. Why don't we run a few tests, this year to make sure that there's nothing we're missing, right? Because, it's very beneficial. Like, it's so much better. They say like an ounce of prevention is worth a pound of cure. Like if you can find a problem, even if it's 30 seconds before a person has a heart attack, okay, the difference between that and 30 seconds after a person has a heart attack can be life and death. And so to me, I really try to encourage people to get tests even before they're symptomatic at a certain point in time. I'm not saying, the healthy 20-year-old who runs track should go in and have an echocardiogram, but I'm saying, look at your risk factors. We know the risk factors for heart disease, right? So it's like gender, males more than females, age, the older you are, so we just as a little aside, which is an important aside, we have modifiable and non-modifiable risk factors for heart disease, right? And when we talk about heart disease, I'm talking again about those three systems. So arrhythmia, coronary insufficiency, and heart failure, but non-modifiable, age, okay, gender, okay, although some people debate that, okay, but when, I'm saying natural gender, okay, so males are being higher risk than females, race, okay, with African Americans having higher risk than Caucasians, people of color being higher risk than Caucasians, and also, I'm forgetting one, heredity, right? So they say you could pick your friends, you can't pick your family, right? Or they say you can pick your friends and you can pick your nose, but you can't pick your friend's nose, okay? Just keep that in mind. See, in addition to cardiopulmonary stuff, I try to give you practical life advice as well. So don't pick your friend's nose. But the idea is that, so if you're a male, okay, if you're an African-American male, age 75, with a strong family history of heart disease, well, guess what? You're 4 for 4, right? Those are non-modifiable risk factors. And when we talk about modifiable risk factors, we're talking about things like cigarette smoking, obesity, blood pressure, cholesterol, stress, you get the idea. Things we can change, right? And the thing is that if you're looking at this and you're taking an honest look in the mirror and you say, well, I'm overweight, I don't really exercise that much, I'm 52 years old, I am diabetic and I have hypertension, right? That's something that you might say, hey, you know what? Normally we might wait till you're 65, but you have all these risk factors. Why don't we get a jump on this and find out 10 years early so that we can treat you and treat your, cholesterol more aggressively, or treat your blood pressure more aggressively, or treat your diabetes more aggressively, or get you on a weight loss program more aggressively before these kind of fixed changes occur. And you're right, Joanna. I don't know what your specific question was. Was it if it was really about what do you do and how do you get these tests? I think it's a conversation with your doctor. And I think that if you can't have those conversations with your doctor, then it's worth looking for a doctor who you can. But I think that the majority of doctors are willing to have conversations like this.
Yeah, I think so. I think so. Thank you.
Sure. Brian Patterson, B. Inder, you're on deck. So in 19 minutes and 30 seconds, please unmute. Brian. Brian, your hand is up. Do you have a question? You are muted still. Up. You almost were unmuted. Hold on. Yes.
There I am. Okay.
Go for it.
You talked about angina. Is there a way for I, as a person, to identify clearly angina pain, or are there different symptoms of angina pain? I asked the question because I also have serious shoulder pain, and I don't think I can distinguish between the two of them.
Okay, that's a great question. Okay, so when we talk about symptoms, okay, there is a formula that I use, and it's called, you probably know it. If you know the alphabet, you know it, but it goes like this: OPQRST, but it's not UV. It's OPQRSTI, okay? And I learned this when I was working EMS. So when I come to your house, I'm going through this formula in my head, and what it stands for is this: onset, provocation, palliation, quality, radiation, severity, timing, and interventions, okay? What does that all mean? It means you're telling me you want to know if your chest discomfort or shoulder discomfort is coming from your heart, or is it a muscle spasm, right?
Yeah.
And these are very real questions. And, it's a challenge often when somebody has substernal squeezing chest pain with radiation down the left arm. That's classic chest pain, right? That's classic acute coronary syndrome chest pain. It's jumping right out. It's biting you, on the butt, or, as we said before, the ass heart. But the thing is that it's when it's subtle, or when you do have lung disease also, or when you do have, musculoskeletal problems also, or you do have GERD also, right? How do you distinguish those different things? So OPQRSTI works like this. Tell me about the onset. What were you doing when what do you do when you experience this pain? So if you're sitting in a chair and you're watching TV, and it doesn't matter what you're doing, and the pain is there and it's constant, that's one thing. But if you say, you know what, I was out shoveling snow, and every time I shovel snow, I get this discomfort in my shoulder, or I get this discomfort in my neck, or I get this discomfort in my jaw, or I get this discomfort in between my shoulder blades or under my shoulder blades, right? Now, those are question marks, right? And I say, let's go a little bit deeper with this. So, you're out shoveling snow. Well, we know that shoveling snow is going to make the airways tighter, which means that you're going to be able to deliver less oxygen, right? So even if your heart is pumping well, you're going to have less oxygen because your respiratory system is affected. There's definitely an increased demand, right? We know that the cold is going to constrict your blood vessels and you're exerting yourself. So is this suspicious? Yes. Okay. So we look at provocation and palliation. Provocation means what makes it worse. Palliation means what makes it better. So if you say, you know what, I'm walking up the stairs, I live in a 3rd floor walk up, and every time I get to the 2nd floor, I get this discomfort in between my shoulder blades, and I have to stop for a minute until it subsides. Or I live in a 3rd floor walk up, every time I get to the 2nd floor, I have to stop because I can't breathe. I have to stand and do the controlled breathing techniques, and then I can continue. Or every time I get to the 2nd floor, I can't breathe and my airways tighten up and I take some albuterol and I go the rest of the way. Or I get to the 2nd floor and I get this discomfort in my shoulder blades and I take a nitroglycerin and the pain goes away and I can continue. You see how the provocation is the increase in demand, right? That's what caused it, the idea that you have to go up the stairs because there's a greater demand, maybe in the context of a lesser supply. And then what palliates it, meaning what's going to make it better, can also point to us and tell us, well, that's suspicious also, right? Then we talk about quality of discomfort. And when it comes to chest pain, okay, the first thing I ask people is it sharp or dull? And if somebody's a nervous wreck or they're panicking or they go, oh my God, it's sharp, it's sharp, it's sharp. And you say, can you show me where it is? And they go like this and they point their finger. And if their finger's not broken and they can point to where, it actually is, right? And it's a very discrete area that we can put our finger on and we can reproduce the discomfort, right? I can press it and I can reproduce the discomfort. Well, if I can reproduce it by pressing it, that's probably not your heart. That's something musculoskeletal, right? Another question I'll ask people is, does it feel like it's inside or outside, right? Heart pain is not like it feels like, oh, I moved my arm the wrong way and I feel this discomfort. But also sharp pain is not classic for the heart. So if somebody's got sharp pinprick pain, that's not the heart. The heart is very often a squeezing pain, right? A pressing pain. If somebody makes this is called Levine sign, right? And if somebody does this is kind of classic of cardiac pain or cardiac sensation. And, there's a phrase, it feels like an elephant is sitting on my chest, right? And one of the respiratory medication companies started using that in their commercials, and they did a massive disservice to every person who's ever had, is having, or going to have a heart attack, because an elephant sitting on my chest is kind of like a classic descriptor of you having a heart attack. It's not your airways getting a little tight, because of asthma or allergies. And I think they co-opted it, which was bad. But you see that the different qualities of discomfort, okay, can also point you in one direction or another. Then we have radiation, right? So classic chest pain is substernal chest pain, meaning underneath the sternum, which is our breastbone, right? With radiation down the left side or arm, right? Radiation can be like it comes from one spot and it goes down and continues to another spot, as compared to referred pain, which referred pain would be, I'm really having a problem with my heart, but it's referring to my shoulder blade, right? Or I'm having a problem in my neck, but it's referring to my fingers. Or I'm having a problem in my lumbar spine and it's referring to my legs in the form of sciatica, right? So that's radiation. And then the other thing is severity. So on a scale of 1 to 10, how bad is it? Timing, is it constant or intermittent? So if you have chest pain that lasts 20, it's there all day, every day, that's not your heart, right? If you have chest pain, and another thing I'll ask people is I'll say, when it comes on, does it flip on like a light and then go away like a light? So up, down, chest pain, no chest pain. or does it kind of ramp up slowly, increasing in intensity? And when it goes away, does it sort of ramp down slowly, decreasing in intensity? The ramp discomfort is usually more predictive of the heart, okay? And then finally, intervention. So what do you do for it, and what is the impact of it? But the thing is that all of these different things, and again, I talked about typical chest pain, there are things that are known as atypical chest pain and or what we call anginal equivalents. So atypical chest pain, so again, just typical would be substernal chest pain, radiation down the left arm. That's classic, right? But, kind of atypical might be discomfort in the neck, discomfort in the throat, discomfort along the jaw, right? Discomfort in your shoulder, discomfort in your back, discomfort in one shoulder blade, discomfort in between your shoulder blades, discomfort in both shoulder blades, okay? Those are examples of atypical chest pain or atypical angina, okay? Diabetics will not always feel chest pain in the same way that non-diabetics will. Women will not always feel chest pain in the same way that men will, and will often feel it in atypical ways. And we know for a fact that women's complaints are not taken as seriously by doctors, not by every doctor, not all women, okay? But there's a lot of research that shows that women have a harder time getting care for certain things, a harder time being listened to, that a lot of their symptoms are often chalked up to emotional, right? Anxiety or things like that. So knowing that, we have to be even more alert to the fact that, hey, I don't want to minimize this patient's discomfort. I want to make sure that I'm not missing something, even though it's not typical, and even though it's not jumping out and biting me in the ass heart or the arse hat. And you have to look kind of at these various. P.S. I have a very sick sense of humor that the only person I'm trying to impress with it is myself. So don't be thrown by it. I need my own entertainment as well. But the idea of this is that we don't want to say, well, it was on the, sometimes people be like, yeah, you know what, I'm having some chest pain, but it's on the right side, right? That doesn't rule out the possibility. And to me, we're not talking about, is it a hangnail or not? Is it athlete's foot or not? No, I have a patient who's 86 years old who is in phenomenal shape, except for a little COPD. Okay, she had a little COPD, but phenomenal shape. Okay, and then she started having symptoms that were not classic heart symptoms, but if you did some work on it, you would realize that she was having some atypical heart symptoms and or anginal equivalents. And when I talk about anginal equivalents, okay, that could be shortness of breath. Shortness of breath could be an anginal equivalent, meaning that your heart's not getting enough blood flow, and instead of it showing itself in chest pain, it could show itself in shortness of breath. An anginal equivalent could be that you get all sweaty when you all of a sudden you went too far and now you're sweating profusely. So, we have to look at these things very closely. And unfortunately, what happens a lot of times is that somebody, will say, okay, you've been my patient for 20 years. You're my COPD patient, right? You're my COPD buddy. COPD, 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 COPD. And that's all we COPD is your COPD. And we miss everything else, so we don't think of anything else because we know you have COPD, right? But as I said before, maybe your COPD has kept you from doing some of the things that might give us a clue, hey, you also have heart disease, right? Does that answer your question?
It does, and thank you very much for that.
And if in doubt, check it out. I learned that from
I
Johnny
will.
Cochran.
Yeah.
I learned that from Johnny Cochran. He's like, if in doubt, check it out. I mean, and that's the way you do. There's no harm in getting a test and having it be negative. There's no harm in getting a test and finding out you're okay. There is harm in not getting the test and having a heart attack, which is what wound up happening to my 86-year-old patient. Very active person, golfer, still very active, travels a lot, okay? And now, because of this massive heart attack that she had, she's significantly more limited. And the sad part is that over the course of a year, and in reviewing her medical records, it was over the course of a year that she was complaining of some of these atypical, anginal equivalents that had it been caught, again, 30 seconds before the heart attack instead of 30 seconds after the heart attack, her whole life would have been different, because the difference between angina and a heart attack is angina is what we call reversible ischemia, meaning that you're not getting enough blood flow, right? But when you stop, it goes away and you get enough blood flow. Once you have that heart attack, your cardiac muscle is impaired, right? And that doesn't recover. You have cell death. And that's the difference. And, there's something called the golden hour of heart attacks. And I don't want to romanticize the heart attack, but it has to do with the fact that, the first hour is crucial. And, again, a lot of times, if you're suffering from chest pain, if you're having something that you're not sure what's going on, go to the hospital, because most hospitals are in a position. And in New York City, they're with they're called STEMI centers, which means ST elevation myocardial infarction center. ST elevation is something that we see on an EKG that indicates that you could be having a certain type of heart attack. And when EMS calls ahead and says, hey, we're going to the STEMI center, we have an ST elevation MI, they get the cath lab ready. Okay, you go right to the cath lab, you skip the emergency room, go in, and if it can be reversed, then there's no heart damage. They say time is muscle, right? And so, I encourage people all the time, and I do this in my work, I do this in my everyday personal life, and I used to do this on the ambulance. Again, if you think there's a problem, check it out. There's no harm in going in and finding out everything's okay. But waiting till tomorrow could be the difference between life and death.
Thank you. Thank you.
You're welcome. Any other questions? I don't see any hands up. Sue Butler, go for it.
Can you hear me now?
Yes.
Okay, so I didn't realize that you were really going to talk about heart issues so much tonight.
I didn't either. I never know what I'm going to talk about until I get here.
Okay, so I have a very rare form of an ILD. It's called PPFE.
Yep.
Most of the scarring in my upper lungs. So I have shortness of breath on exertion. I do not have low oxygen.
Okay.
My oxygen will drop when I'm exercising, and I'm on a very strict exercise program and take that real seriously.
Mm-hmm.
I'm going on a trip this summer where the elevation is 3,400 feet. And my doctor suggested that I get a portable oxygen concentrator and have that with me, and it may just make me feel more comfortable. And I wondered, first of all, you always say the Care Company is your favorite oxygen provider. And I looked up some of their products, and their portable oxygen concentrator looks just like what I really need.
Which one? Do you know which one?
It's called the, I wrote it down somewhere here. I'll find it in my notes in a minute. Freestyle Comfort.
Okay.
It's just a small one, and it curves to your body, and you wear it on a shoulder strap. So I called a local company to see what they had. I still don't know if my insurance company will pay for it. I doubt that they will. They would only rent one to me if I was currently one of their oxygen patients. And they also said that they're in very short supply right now. And so even if I decide to go ahead and purchase one, I'm not really even sure I can get one. So
Get one.
I'm sorry.
I can help you get one for sure.
That would be great. They're checking with my insurance company right now.
It may not be covered by insurance.
Right.
But
Okay, so I was curious, why do you think they're the best? Do you know anything about that particular model?
Yeah. So let me back up a little bit. So, you talked about a number of different things there. Okay. So number one, you talked about PPFE, right?
Right.
So, PPFE, it is rare. Okay. It's usually upper lung ILD. You first said that you have plenty of oxygen, but then you said you desaturate with exercise, right?
Well, when I'm exercising, I might go down to like 92 or 91. I've never really been in a situation where I feel like I'm in stress. And then as soon as I sit down, it comes right back. I might
Is
start it,
91 the lowest you've seen?
might go to 90, but that's a little more rare. I might start out at like 97 and drop to 91 or 92,
Mhm.
but then it comes right back again. But my heart
Okay.
rate goes very high. My
Okay.
heart rate can go up to 115, 120,
Can I ask your age? If you don't
77.
want to tell me, you can lie.
No, that's fine. 77.
Okay.
And I was diagnosed last year. It's just about a year right now.
So first of all, the number of people with PPFE is so minuscule that hardly anybody knows what to do with it. Okay.
Yeah, the doctor told me there's 200 cases in the world.
Exactly. There's very, very minimal. But there are a few caveats, and this is not just for PPFE. This goes for anybody with any type of kind of oxygen, whether it's respiratory disease or cardiovascular disease. The considerations are as follows. Number one, resting requirements, right? So I talked before about supply and demand, and the thing about that is that when we sit and do nothing, the demand is very low, right? So if you think about it, when I'm sitting here doing nothing, I don't have a great demand. And so even if I have a problem with my heart, or even if I have a problem with my lungs or a problem with something else, I may not know that problem until, until the demand increases, right? So
Right.
sitting perfectly fine. But when I need a greater demand, then I may not have the supply to meet that demand, right? So that's one thing. And the other thing is, so 3,400 feet, it's altitude, it's not that high, but I just want to say that when it comes to altitude, and I've traveled a lot at altitude, I've been as high as 15,200, and various kind of levels in between, but I've had problems in certain places. Like, for example, I had one trip where I was in Mexico City, which is somewhere between 3,000 and 4,000, and I had more difficulty for some reason in the first couple of days than I did at 15,000 feet in Peru. And so, it's not 100% linear. Like you say, well, I was fine this time at 3,700. So that means at 3,600, I'm going to be perfectly fine, because it's not just the altitude itself. There's other factors that come into play. When it comes to, altitude can drop your oxygen. Okay. It can make it harder for you to breathe, but shortness of breath doesn't always correlate one-to-one with oxygen saturation. So in other words, you can be very short of breath and your saturation can be fine, or your saturation can be low and you may not be that short of breath. In your case, and really in everybody's case, I say all the time, rely on your instruments, right? And what I mean by that is there's three people that need to rely on their instruments: scuba divers, pilots, and pulmonary patients. Okay. Why? Because when you're scuba diving, okay, water looks like water, and you can't tell the difference between it being at 20 feet and 50 feet and 100 feet. Water is water, so you need your depth gauge. Okay. When you're a pilot and you are in the air, air looks like air. And you can't tell the difference between 30,000 feet, 40,000 feet, and 50,000 feet. So you have to, rely on your altimeter. And with pulmonary disease, you can't always tell. It's not like, you go to the carnival, they guess your age, they guess your weight, they guess your oxygen saturation. Okay. And a lot of times people think they are, very in tune with their numbers. Maybe they are, maybe they aren't. Some people are more than others, but always rely on your saturation. So there is a test called the HAST, okay? And the HAST is a test that, there you go, Beth. But the HAST is a test, it's called High Altitude Simulation Test. And it will tell you when you're at altitude, either during a flight or at altitude like Mexico City or Peru or someplace like that, are you gonna be okay? And if you really don't know if you're gonna be okay, then it's worth getting that test, okay? Now, you asked me if I know about different machines, okay? So I wanna, Beth, if you could put a couple of things in the chat for me. I wanna put a couple of things in the chat, which you can check. One of them is called Oxygen Manifesto. It's 3 pieces that I wrote about oxygen saturation and when you should and shouldn't be using oxygen and why. And I've written them with Mark Mangus, who I call Respiratory Therapist Laureate. Donna Fraunfelter, who is the person that literally wrote the book, The Godmother of Pulmonary Rehabilitation, Marion Mackless, who was my colleague since 1998, rather 1994, I'm sorry, and Ryan Deesum, who is the person that I consider to know the most about oxygen concentrators. So read those, it's going to put things in really good perspective. But then the other thing is the pulmonary paper, okay, which I'll just share my screen with you for a second, has an annual guide written by the person I just spoke to you about, Ryan Deesum. And in it, it has all of the different concentrators, right?
Yeah.
And when it comes to concentrators, okay, I was in this drugstore on 2nd Avenue and 33rd Street, and they have a sign up and it says, when it comes to a construction job or a contracting job, people want 3 things. They want it to be fast, they want it to be good, and they want it to be cheap. And you can have any 2 out of the 3. You can't have all 3. And when it comes to oxygen concentrators, people want 3 things. They want it to be small and lightweight, they want it to give a lot of oxygen, and they want it to last a long time. You can have any 2 out of the 3. Now, the thing about these, okay, the most basic delineation is it intermittent, meaning pulsed, or is it continuous oxygen? Continuous oxygen, like the name sounds, means oxygen is continuously flowing out regardless of what you do. And pulsed means that you should only be getting the breath, the oxygen coming out when you're taking a breath in. And in that way, it is supposed to be conserving, which it is, but it doesn't always give you enough oxygen. So the key in getting a good concentrator, or the right concentrator, really is making sure that it's going to be adequate to keep you, well saturated under all the conditions you need to be. Otherwise, there's really no point in doing it. But if you look, another point I'll make is that, when you see the numbers, like sometimes they'll say you see these settings, 1 to 5, 1 to 5, 1 to 5, 1 to 5, 1 to 6, 1 to 3, 1 to 5, 1 to 5. These don't mean liters per minute. And this is a mistake a lot of people make. But what happens here is, if you look at this top number, it says maximum oxygen production in milliliters per minute. So this one provides 1,000 milliliters, which is 1 liter per minute. This provides 1.05 liters per minute, 1.26. You can see that most of these don't provide a lot of oxygen at all, right? So if you have a condition where you really require a lot of oxygen, then these portable oxygen concentrators may not be adequate for you. And if you look over here, the most oxygen that any portable oxygen concentrator gives per minute continuously is 3,000, excuse me, 3,000 milliliters, or 3 liters per minute. So those are things to keep in mind. So there are ways to compare them, ways to find out, but then ideally you want to try them out. You don't want to find out when you're in the hills of Peru getting chased by a llama that, that your oxygen is not adequate for you. So those are things to keep in mind. But again, 3,400 feet, it's not that much, but it might be enough to kind of give you a difficulty. So if you have concerns, if you're not 100% sure, and most things like this aren't 100%, I would ask to have the HAST so that you could simulate the altitude and see what do you need. And it can also help you make a decision as to, will this oxygen concentrator be adequate for you?
Right. And you have to have a doctor's prescription to get one, correct?
In the same way that you do to get heroin. I mean, if you have a friend, then you can get it without a prescription. No, I'm kidding. But I mean, there are concentrators on the mark, or as Mike Hess and John Linnell like to call them, non-centrators. And the thing is that there are ones that you can buy on eBay, right, that are not medical grade oxygen concentrators, okay? And those are not adequate. You need a medical grade oxygen concentrator that you do need a prescription for. I wouldn't try to buy something on eBay or Craigslist or Black Market or anything like that. It's like when you go to Las Vegas and they have those oxygen bars and you could get like pina colada oxygen. Essentially what they're giving you is air. it's not really oxygen. Medical grade oxygen is 100% oxygen.
Right.
You know, and that you can't get without a prescription.
But I called one of our local providers and they told me I would have to show my breathing function test is consistently below 88% before they would even consider.
Yeah, I mean,
those
that's your
oxygen patients.
saturation. That's your saturation. But
Right.
when you exercise, do you wear oxygen?
No,
You
I
don't.
have not used oxygen at all yet.
So
doctor
in my opinion, okay, you should be using oxygen when you exercise. I think you'll get more out of the exercise. And that's what we do. I started treating pulmonary fibrosis patients in 1995. And at that time, there was no OFEV, there was no Esbriet, there was no treatment. And so if you think the diagnosis of ILD is bad now, it was practically non-existent then, because doctors felt like, well, why should I diagnose it? There's no treatment. They didn't even look for it. But at those times, you know, what was happening is these patients would be, you know, we had a very similar type of experience with pulmonary hypertension too, because PH and PF have, you know, are conditions in which the saturation can be significant. Like people can go from 98% at rest to like 70% with minimal exertion. And, you know, a lot of these patients were basically not allowed. They were told they're too sick for rehab. There was no rehab for them because, you know, usually the main reason was because the staff of the rehab is afraid. So, you know, I had a very, very kind and gentle and benevolent mentor named Horatio Pineda. And, you know, it used to hurt us. It used to hurt our hearts in a different way than OPQ-RSTI. But it was like, it sucked to have these patients who came in, and very often we were their last hope. And to hear that you're too sick for your last hope, it's like Alfred Hitchcock's Lifeboat, where it's like, okay, we're going to put you out of the boat. But what we started doing in 1995 was we started giving people as much oxygen as they need, not as it needs. I mean, I could say if it was like a donkey, I could say we gave the donkey as much as it needed. But you know, I call myself Malcolm X rehabilitation, which is by any means necessary. And, you know, we have patients who will give 15 liters of oxygen to 20 liters, 25 liters, and we'll give them masks. And we exercise them under those conditions. And what that does is by allowing them to exercise under those conditions, their bodies can adapt and their bodies actually get better at using oxygen. The heart becomes more efficient, the muscles become more efficient, and the lungs become more efficient. So, you know, that's a story for another time. But my guess, based on the fact that you said that you can start out at 97 and desaturate to 91, I'll tell you a little industry secret. It's not really an industry secret, it's a pulmonary wellness secret. But I bet if we ran you up and down the halls, we could get you into the 80s. And all we have to do is document it, not continuously. We just have to document it that when you're under stress, you go below 88%, and that will qualify you.
Yeah, I don't think I've ever done that.
Well, you may not have pushed yourself hard enough. And I'm not saying to do it on your own, but, you know, if we ran you up the stairs a few times, you might.
Yeah, yeah.
But we would have oxygen ready so that as soon as we got the number we needed, we could give you oxygen. So.
Right.
All right, 2 more questions. B. Inder. Beverly Holtzman, final question on deck. B. Inder. I can only assume you're in witness protection. Respect, we won't tell anyone where you are.
Okay, it said host will not unmute you is what happened. Okay, well, I started out not having the courage to ask the question and raise my hand. And since then, the question has evolved. So let me give you a little synopsis.
Okay.
I'm 80.
Okay.
I look younger than my years. I'm at my right weight. I'm 125 by 4.5. Pre-diabetic, got my scores down to 5.9. I have MVP and I have preatrial beats.
Okay. So
And
mitral valve prolapse and premature atrial contractions.
Oh, is it contractions? I thought it was beats. Okay.
Well, it's the same thing. It's a beat. It's a premature atrial contraction.
Right. And at one point I was told I had COPD, and then I went to a different doctor and they said I have asthma, and so it's under control. So I'm taking it as asthma. I got a couple parts to the question. Let me ask them all together and maybe you can synopsize. For the preatrial, Dr. 1, 2, and 3 said, all I have to do is educate you that it's a benign condition and you have to learn to live with it. And I didn't buy that. So I went to the next doctor and he put me on beta blockers. And lo and behold, I was better. My extra beats went away. And then the doctors were saying, oh, you're doing great. Stay on it. You know, all the doctors that said, don't take it. Okay. So we have that managed. Then I was in the ER for an unrelated problem. I had the most severe pain of my life. I had some kind of infection in the root of my teeth and beyond belief pain. And it happened that I was wearing a 24-hour Holter monitor. And they gave me the appropriate meds and discharged me. And I said, you shouldn't be discharging me. My heart is going 1,000,000 miles a minute. This is before I was on the meds. And they did my blood pressure, and that was it. And they said, you can go home, you're fine. And they started to explain to me that the Holter monitor wasn't affecting my heart. Like I didn't understand that it was a test. I got the results of the test and I had 23,000 extra beat in 24 hours. So the first part of the question is, how do they not recognize this? Then I had another question that came to mind from what you were talking about in the last question about bringing oxygen. I never connected these two, and I'm wondering if there is a connection. I have a sleep problem. I actually sleep too much, and I have a delayed sleep pattern. So I had a study done, and they said to me, you can't sleep on your back. Your oxygen falls in the 80s. You have to sleep on your side or you have to take oxygen. And I didn't want to take oxygen. So for 6 months, I've been trying to sleep on my side and I haven't been successful. So I never connected the heart, the lungs to the low oxygen saturation. That's my questions.
Okay, so a couple of things there. So here's how I would break it down. Asthma versus COPD is easy to figure out. Okay, you get a pulmonary function test. Number one, they're both obstructive pulmonary diseases, right?
Right.
And that gets confusing for people because asthma is a chronic obstructive pulmonary disease, but it is not COPD, right? For people, you know, some people will say COPD is a quote umbrella term that includes many, many different diagnoses. I don't think of it that way. I think of COPD as chronic bronchitis, which is disease of the large airways, and or emphysema, which is disease of the small airways, and the alveoli, which are the air sacs. And the thing about that is that when we talk about COPD, there's something that is called a fixed airway defect. And when we talk about asthma, we talk about a reversible airway defect. And when you get your pulmonary function test and you take a deep breath in, they ask you to blow it out as hard and as fast as possible. That is the maneuver that will elicit the airway obstruction in both COPD and asthma, okay? The difference between reversibility and fixed is that when you are given a bronchodilator, right, if your airways respond to the bronchodilator and become less obstructed, that's called reversible airway disease. And that points more so to asthma, as opposed to somebody who's a non-responder to the bronchodilator, and that's called fixed airway obstruction. And that points more so to COPD. Now, that being said, there are times where, you know, somebody will be a non-responder to the test, which is an awkward test at times, especially if you have difficulty breathing. And so therefore bronchodilators won't be recommended because they'll say, well, you didn't respond to them on the test. But I can tell you from thousands of people, well, maybe not thousands, but certainly hundreds of people, that even if you don't respond during the test, there are people who will get symptomatic relief from the bronchodilators, even if they don't show it on the test. So I wouldn't rule it out there. So that's number one. Finding out if you have COPD or asthma, it's easy to do. There's a definite way to do it. Number two, I'm not sure where the mitral valve prolapse comes in. Although actually I am sure, because I'm not sure, but when I talked before, just give me 1 second, please. So I spoke before about mitral insufficiency and mitral regurgitation. So the mitral valve is what's called a tilting disc bicuspid valve, okay? And what that means is that there's two cusps and they go like this and they respond to pressure. So what's above my hands right now is my left atrium. What's below my hands is my left ventricle. And when pressure in the left atrium exceeds pressure in the left ventricle, the mitral valve opens. And when the pressure in the left ventricle exceeds pressure in the left atrium, the mitral valve closes again. If the mitral valve doesn't close completely, that's called mitral insufficiency. And if the blood flows back from the left ventricle to the left atrium, that's called mitral regurgitation. Now, there's something else. There's something called mitral valve prolapse, okay? Now, what mitral valve prolapse is not only that it doesn't close completely, but the mitral valve can actually go back into the left atrium, okay? And that alone can trigger premature atrial contractions.
Oh.
So the thing
Okay.
about it is that can create what we call an ectopic focus. So in the same way that an ectopic pregnancy is outside of the normal, areas where a pregnancy occurs, this is an area that's causing a contraction that's outside of the normal electrical system of the heart. And the thing about that is, as your doctor said, it's generally benign and uncomfortable, but it can be managed with a beta blocker. But it's not going to kill you, and there's really no downside to it. And when it comes to arrhythmias or ectopic beats, okay, premature atrial contractions are much less significant than ventricular contractions that are premature, because the left atrium really only contributes about 15 to 30% of the end volume in the left ventricle, right? Whereas if you had, now I would check that number, 23,000 in 24 hours sounds like a lot, okay? And I can understand why that would make you uncomfortable. I suspect it's probably not that many, but it could be, I could be wrong. But in general, once the number of premature beats, when you think about it, like, generally we think of like 10 to 15% of a person's heartbeat, if any more than 10 to 15% being premature ventricular beats, or more than 100, up to like 100 or a couple of hundred in a 24-hour period is acceptable. But again, ventricular beats are much more dangerous than atrial beats. So in that respect, I would say, you're right. Your doctor, they all gave you the right advice. You don't believe them. For some reason, you're looking for me to give you something different.
No.
But they're right. And
no,
the
I
thing
believe
is that if it's uncomfortable for you, then take the beta blocker. No harm done.
I've been taking the beta blocker since before COVID, and I like it. It makes me feel better.
Perfect.
And I believe them. I'm just saying the 23,000 in the ER, I was told because I had this rip-roaring infection. And
I mean, that's very possible too, but I bet it's probably also related to your mitral valve prolapse. And then the final question is, you talk about sleeping and oxygen. If you're desaturating at night, I mean, people have very little control over, most people, when they lie down, they're going to have a little more difficulty breathing because everything gets pushed up, right? And the diaphragm is now, working against gravity to contract. And so if you do have some type of respiratory condition that can, that can decrease your supply of oxygen, then lying flat can exacerbate that. But if you do have asthma or COPD, and you do have these arrhythmias, in my opinion, the oxygen at night would be very good for you because, because it will not only allow you to, to be well saturated, but it will also protect your heart. And the odds of you being able to really control your position while you're sleeping are not that great.
I agree with you. I've been trying for a half year. And
Yeah.
they say, well, sleep with this backpack kind of. I can't sleep
No. We used to do something, it used to be like where you sew a tennis ball into your
Yes,
shirt,
yes.
things like that. But
I
use the
tried
oxygen. It's going to give you benefit in a lot of different ways.
And there are oxygens that are small enough where it won't be a whole
Well,
architecture.
for sleep, you're going to
Yeah,
get a machine. You're going to get a home unit that plugs into the wall.
I'll ask CARE. And what do I ask them specifically?
Well, you ask your doctor to
Okay.
prescribe the home oxygen.
All right. I was trying to avoid it, but I think I'm giving up. Thank you.
You'll feel better. Last question, Beverly Holtzman. You're muted still. You're muted still.
Crap. Okay.
Now you're good.
Hi.
Just in time to hear you say crap. Perfect.
I just pressed the unmute and I pressed the mute. Just to respond to the other lady, I've been using oxygen for 20 years. I use it for sleep. It's not a bad thing. It's really good. I've had sleep.
Hold on a second, Beverly. You're not trying to take over the show, are you?
No.
All right.
No.
Continue. As long as I know you're not getting your name on the show. Go ahead.
I wanted to confirm to her that it's not a bad thing. It's good. It's quite comfortable. You have this long 50-foot cord. It's only in your nose. I've had sleep studies where if I sleep on my back, I have sleep apnea. If I sleep on my side, I don't. So I'm using the oxygen. I sleep on my side. And because you can't judge it's really comfortable and it's really good. So it's not a bad thing. It's not scary or anything. Go for it. My question is, again, I think I asked this the other time, but I just want to ask it again. I had a rare lung disease, lymphangioliomyomatosis.
Bam.
I had a lung transplant. Now I have COVID lungs. So I have a home oxygen. I just didn't qualify because I didn't go below 88, and then you're not covered by the government. But using exercise, I go to 92, 93, from 96. Sometimes I do, sometimes I don't. My husband and I have an argument, put the oxygen on, don't put the oxygen on. And you suggest, and the doctors too, all the doctors, all the respirologists say, don't use oxygen if you don't go below 90. But
Disagree.
I
would have agreed up to COVID. Well, yes and no. I would have agreed and disagreed. So the answer is, go ahead, finish, and then I'll tell you. Well, I already know the answer, but go ahead.
I'm just so encouraged by what you're saying, by telling people that even if you're at 92, put the oxygen on, because
so that's not a definite. That's a maybe. Okay, that's a maybe dependent on other factors. Okay, so as an example, and this is what a lot of people misunderstand about COVID, is that we don't just use oxygen for saturation, right? Yeah. Certainly we do use it for saturation. So if you desaturate, it's a no-brainer. You have to use oxygen. Okay. But there are people who, even if you don't use oxygen, even if you don't desaturate, people with coronary insufficiency, okay, by bathing the heart in oxygen, we increase the pressure gradient and you will be better saturated and your heart will be better nourished. In pulmonary hypertension, by giving you oxygen, it can help to relax the blood vessels and decrease the total peripheral resistance. In COVID, it can help with autonomic dysfunction. And bottom line, you know, and, you know, I come from Brooklyn and I come from a hip hop background. So take what I'm about to say as you take it, but I get better results than anybody else. So, you know, and when people argue with me over that, I say, well, why don't we have a little contest and we'll randomize some patients, and I'll put the keys to my center on the table and you put the keys to your center on the table. And whoever gets the better results gets both sets of keys. And no one's ever taken me up on it yet. But the idea is that, well, first of all, when you say you have COVID lungs, what do you mean by that? Do you mean you have pulmonary fibrosis? I was wondering who was heckling from the side, and now I know your husband's there, disgruntledly grunting, because he was hoping I would say, you shouldn't be wearing the oxygen.
No, he's agreeing with you. He
Oh,
agreed-
okay, then he's very wise. But the thing is that when you say you have COVID lungs, do you mean you have pulmonary fibrosis?
They don't know what I have. I've had a transplant, as we know, and I got COVID. So now I have COVID scar tissue. So
Okay, so you
they
do
don't-
have fibrosis. When did you
Yeah.
have COVID?
May, June 2021. So I
Okay.
had my in 17, really bad recovery, but I recovered and I got strong. 4 years, then I got COVID and came home back on oxygen. And
Do you have
since
a CAT scan?
I have, yeah.
Okay.
No, not a CAT scan not a CT scan since COVID.
Okay, but you had a CAT scan when you had COVID, right?
Yes, I have that.
All right, so here's what I would recommend. Number one, ask your doctor if you can have another CAT scan. Why? Because when COVID first came out, okay, what did we learn? We learned it's a respiratory infection that, lasts for 10 to 14 days, blah, blah, blah. And there was this whole kind of line of thinking, are we going to wind up with a whole new crop of lung transplant patients related to interstitial lung disease related to COVID? And to me, it didn't make sense because, interstitial lung disease doesn't usually work like that. And what I initially thought wound up being, I believe, if not 100% proven, it was kind of alluded to that it's true, which is that a lot of what was initially thought of as scar tissue and fibrosis actually turned out to be inflammation. And one of the confusing factors about that was there's something called ground glass opacities, okay? And what that means is that these are areas of increased opacity, meaning more, they show up more prominently on a CAT scan in the form of what looks like ground glass. And a lot of that has resolved in people who were initially diagnosed with fibrosis. And part of what we think about that is the fact that the inflammation has gone away. And so I would recommend, number one, asking for another CAT scan. And one thing that, if you've heard me talk about ILD before, the most important thing is getting the right diagnosis. ILD is an umbrella term, and there are many, many different types of interstitial lung diseases. And depending upon what the root cause of it is, the treatment can vary in effectiveness, and some being very, very effective. So there's that. And then the other thing is that when it comes to COVID long haulers, okay, we have found that oxygen is very beneficial, even if the person doesn't desaturate. And a lot of people with COVID don't desaturate at all, but we still get benefit from the oxygen in terms of cardio protection, in terms of less shortness of breath, but also in terms of autonomic dysfunction, which in many cases is the big issue when it comes to COVID. So I'm all about the oxygen. To me, there's no downside. There's no downside to oxygen. Yes, there are people who are going to be like, oxygen's a drug, man. You can't be doing, don't take too much. You're going to overdose on oxygen. Or people are going to say, you know what, you could get oxygen toxicity. Or they say, well, no, you're going to stop breathing. None of those things are true. Okay. And
Because I do get short of breath.
I'm doing a monologue. Give me a second, Beverly. No, I'm kidding. Go ahead. Go ahead. I'm just kidding.
When I do walk, I do get short of breath. And but I don't desat. But you know,
So
Henry,
shortness of breath is different than desat. And if you look at one of the things in the chat, if you look at Pulmonary Oxygen Manifesto Part 1, I
Yeah.
talk about the difference between shortness of breath with and without desaturation and who should. But COVID has really not so much changed, but certainly reinforced my belief that oxygen has many more benefits and should be used in cases other than just pure desaturation. Now, trying to get oxygen can be hard enough even when you do desaturate. It's hard to get it if you don't desaturate. But you know, hopefully, when we put out some of our study results, people will be more open to the idea
Right.
of using it.
Right.
All right, I'm going to make one exception. Last question, Helen Buick. Otherwise, I know I'm going to suffer. Go for it, Helen. Ask your question. And don't say I didn't call on you. I'm calling on you now in overtime. Helen, you're still muted. Helen, do you have a question? Yes.
Oh,
Okay,
I
there you
have a
go.
question. Okay. I have one question.
Yes, ma'am.
What is your opinion on, I see advertised liquid oxygen?
So liquid oxygen is great. Okay. It's very hard to get because number one, it's expensive and it's difficult to upkeep from the oxygen company. So with liquid oxygen, as compared to the gas or as compared to a concentrator, so the gas is a tank. It comes like gas in your car. You use it and then the tank is empty. Okay. The tank gets filled by the people, by the oxygen company. The concentrator will extract oxygen from the air itself, right? The limitation of that is that, you know, you're basically literally splitting the atom or the molecule, and there's a limit to how much you can get. Liquid oxygen will allow you to have a reservoir of the liquid at home when it's brought to a certain temperature that you can then fill your own device with it, and it can give you very high liter flows. So in other words, it gives you the maximum liter flow almost as much as a tank, but it's very hard to get. Most oxygen supply companies don't even carry it anymore because of the hassle. There's this whole thing where a few years ago, the oxygen companies were, you know, and basically durable medical equipment supply companies in general were ravaged by, I think it was called like by competitive bidding, where they can't possibly service it. So in you know, as an actual, what is it? Liquid oxygen is great if you could get it. In New York City, I don't know anyone who carries it. I do know some people who still have it, who are lucky, but I think it's going to be phased out over time.
Thank you.
Yep. All right, everybody. I think that's a wrap. We're 1 minute short of 2 hours. Again, I hate to ask for anything, let alone money. However, when you think about the various organizations out there, think, can I call up X, Y, and Z and ask them a question? No. Can you call us up? Yes. Put your money with the people that are going to help you and give you the answers you need. Have a great week, everybody. Please, there's a link in the chat, and I'll put another link in the chat right now to our donation page. As I say all the time, if you're going to give away your money, you might as well give it to the Pulmonary Wellness Foundation, where you know it's going to come back to you. And I trust me when I say I hate asking for money. I hate asking for anything. If you know me, you'll know that that just made me sick to have to say that, but it's helpful. Have a great week, everybody. Now, one thing I want to tell you about, June 18th, broadcast, it's a Saturday, broadcasting live from the Oxygen Forest in New York City. I'm going to have Brian Traskos, who, if you do boot camp, then Brian is responsible for our Tai Chi and Qigong. And we're going to be talking about a lot of cool things, some cardiopulmonary in nature, many not necessarily cardiopulmonary, but life in nature. And it should be a very great talk. Brian is phenomenal, very powerful individual who knows a lot about a lot of different things. And he's an awesome, wonderful human being. So have a great week, everybody. Hope to see you on the 18th. And empty your pockets into that link right over there, people. Passing the hat. Have a great week, everybody, and we'll see you on the 18th. Bye-bye.